This podcast does not provide medical advice. Please listen to the complete disclosure at the end of the recording.
Hello, everyone, and welcome to Everyone Dies, the podcast. I'm Marianne Matzo.
I'm Charlie Navarrete.
So please grab yourself a nice cold beer, some pepperoni pizza, hamburger. I don't know. I haven't had lunch yet, so all of that sounds good.
It does sound good.
And thank you for spending the next hour with Charlie and me. In the first half, we have our recipe of the week and a report from Charlie about funeral cheese. I don't know where he comes up with this stuff.
I don't know, but
and
these crackers
second
too.
half.
Yeah.
In the second half, I'm going to be talking about dignity therapy. And in our third half, we have some insights from our guest expert, Dr. Harvey Chochinov, about his development of dignity therapy and what he's learned from doing this work. Our recipe this week is for funeral sandwiches. Now, this was a new one to me. Although I've eaten these, I didn't know that they were called funeral sandwiches. Funeral sandwiches are Southern ham and cheese sliders that are baked in a brown sugar Dijon sauce. When the sauce bakes, it caramelizes into a sweet and tangy crust that is out of this world.
Wow.
The sandwiches are kind of hard to explain. They're sort of wet, sort of crispy, but they're really, 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 really good. And you can't eat just one. So, you're welcome. And you can find a recipe on our website. But Charlie,
Yes.
I have been waiting for your report about funeral cheese.
Yeah, me too. I mean, yes, let's get on with the show. So, high in the Swiss mountains of Val d'Anivier is one of the last places you'll find evidence of an unusual practice, keeping a wheel of cheese to be eaten at your funeral. Residents of Grimentz, like people, you laugh. Don't you have a wheel of cheese tucked in your closet? I mean,
I was thinking if I was going to have cheese, it'd be like cream cheese. I'd like a wheel of cream cheese.
A wheel of cream cheese. All right. To each his own. So the residents of this town of Grimentz, like people elsewhere in the Alps.
We have an app for that.
Keepers. All right. So people in the Alps breed cows, adapted to the steep landscape, bringing them. So basically, they breed cows with hiking boots. Adapted to the steep landscape, bringing them to high pasture in summer to graze. Pooling abundant summer milk, they make giant wheels of cheese. While aging can continue for years, most alpine wheels tend to reach peak ripeness, still pliable, but with plenty of flavor, months later, during the worst of winter when, historically, little else was available. Sliced onto rye bread or melted fireside cheese ensured a calorie source in winter. Now, when someone dies, the bells of their cows are removed so that the animals too could mourn. Families at a picnic of the dead. Oh, yes, there we are. As we've spoken about before, your pets are part of that mourning process, part of grieving. Yeah. So the animals
but
too.
I've never heard of a group that took off the bells, so that I think that's very sweet. I think my ducks should not have bells when I die, which would mean I'd have to give them bells now.
Well,
which sounds like a lot of work.
It would be a lot of work. I agree. You got to chase them, make sure that bell is the right size. Otherwise, if it's too heavy, they'll be, walking with their beaks down to their toes.
Or they drown.
Or they drown. Yeah. Instead of saved by the bell, drowned by the bell. Something to consider.
Oh my God.
So, so the bells of the cows are removed. Now, families added a picnic of the dead to the casket, which included a bottle of wine, bread, cheese, and sturdy boots. Okay. boots. There we are. As ghosts were rumored to wander the glaciers after dark.
Is that goats or ghosts?
Did I say goats? No, ghosts.
I don't know. Is it goats?
No, it's ghosts, like Casper.
Oh, okay.
Or Topper in the Cary Grant. Topper. Yes, ghosts. The Ghost and Mrs. Muir. The movie and the TV series.
I loved that film. That film.
Yes. Oh, yes. So getting back to the food in the coffin. So the foods that are left in the coffin were the same foods served at the burial meal. Funeral guests were told, "Come to the meal because the dead man has left enough." Well, yeah, what's he going to do, take it with him? In this historically poor area, leaving enough required advanced planning. There was the cheese of the dead. Everyone had a wheel of cheese so that they had something to serve at their funeral. At the funeral, the chiseled cheese was washed down with vin de glacier, which is basically the local wine. So, I don't know about you, but that sounds good to me. So for this, please go to everyone.
Yeah, but if you live to be 100 years old, can you imagine what that cheese must look like?
Green, maybe blue.
Huh?
I guess.
I don't know that I want to eat it.
Yeah, even if you scrape all the cooties off, I would still be very reluctant to. Better to have a fresh bar of Philadelphia, cream cheese. Yes. Mm-hmm. Yeah, in that case. Yeah. Yeah. Or make it out of Velveeta. That thing will last through the apocalypse. Velveeta. Yes.
That's true.
Yeah.
And there's really nothing like a good grilled cheese sandwich with Velveeta.
I just prefer regular cheese. I've never been a fan of Velveeta.
Even in grilled cheese? Have you ever tried it that way?
I haven't because I wasn't a fan of it not grilled. So just no.
Mm-hmm. No. Some things are just better grilled, Charlie.
Yes, I agree with that. So listen, for other tantalizing recipes like this, including the funeral cheese recipe, please go to everyonedies.org. Link to these recipes and additional resources for this program. That's dies.org. You can email us all your secrets at mail@everyonedies.org. Please follow us on Facebook and Instagram. You would be too cool for school if you would also remember to rate and review this podcast. As a nonprofit, we are always thrilled to accept your donations. Please go to our website to donate and support our work. www.everyonedies.org.
Cool report, Charles.
Hey.
So, in our second half, we're going to tell you a little bit about something called dignity therapy. It's all about kindness, humanity, and respect.
Oh.
These are the core values of health care that need to be safeguarded in our time pressure world. What are you saying? Oh, like
I don't know. I was something morbid. I don't
kindness,
know.
humanity, and respect.
But okay, go ahead. So, what is this about?
So Dignity and Care provides practical ideas and tools to support a culture of compassion and respect throughout the healthcare system. So if you're a patient, you're entering the healthcare system, it really wasn't that long ago that you could be referred to as that appendectomy in room 10 rather than Mrs. Jones with 6 kids who's a single mom and all the other details about you. We're kind of reduced to whatever diagnosis you had. People working in healthcare can have a huge influence on the dignity of those who use healthcare services, which in turn can improve the patient experience and increase satisfaction with healthcare. Good communication is an essential ingredient for providing the best quality of healthcare and safety. So, always, if you're a healthcare practitioner or if you're a family member who's taking care of somebody with a disease, keep in mind the whole person, their body, their mind, and their spirit. The illness itself can lead to concerns about loss of independence, distressing symptoms, overwhelming anxiety. The person's own approaches and perspectives can help to maintain their sense of dignity. The way the person is treated by others can either support or erode dignity. So, how can we help enhance dignity in healthcare? One thing is that we can help to buffer or maybe even get rid of the negative influences on a person's sense of dignity. These are things like affirming the person's value. Make the person feel as though they are seen as the person that they were or are, rather than just a medical concern. You can go in and, let's say somebody's a physician or a nurse practitioner, and you're explaining how to take a temperature. Well, obviously you don't know that I do understand about how to take a temperature, and you're kind of eroding my sense of self by, just talking, explaining how to take a temperature. On the other hand, kind of understanding who we are. I'm a gerontological nurse practitioner. I take care of older people. So when I was pregnant with my first baby, people would say, the doctor would say, well, you're a nurse practitioner. You understand all this. And I'd say, no, old people don't have babies. I don't understand all this.
Right,
this is not what I do.
Right.
So, kind of get it right. Know who we are when you're taking care of us. View people apart from their disease. Communicate and affirm the aspects of their personhood that are not affected by illness. So if you have somebody, let's say, with cancer or with Alzheimer's disease or with Huntington's, there are still some things that people can do. Let them do those things. If they're able to order their own food, or say if they want ice in their pop or whatever it is, let people give them that opportunity to do as much as they can do for themselves. You want to safeguard the person's privacy. Remember, these procedures that might be routine for people who work in healthcare are not routine for most patients. One thing that kind of really gets to me, I'll have to be honest, is people who post on Facebook pictures that are not dignified of their loved ones. And when I see pictures like that, I always say to David, if you ever post pictures like this of me, it might be somebody who has dementia and they just really don't look their best selves,
Right.
or people who are laying in a hospital bed and don't look their best selves, or people who are in their caskets and may not look their best selves. It's like there are some things that, personally, if you're going to put a picture of me on Facebook, make sure I look good. So in dignity therapy, we're making sure that people are represented the way they want to be represented. And making treatment of things like physical pain a priority, because it's not honestly dignified to be in pain. When you are suffering and you're in pain, there is nothing dignified about it.
Right.
And so take care of those issues, advocate for your loved one so that you can help maintain their dignities. Deal with fears and anxieties. Provide information about the expected medical course, the treatment options, and the way in which the illness can be managed. Don't just talk to the caretaker. Talk to both people. Include both people in the information.
Right.
You don't know what of any part of information that person might be getting or what they're not. So maintain their dignity, treat them like an adult, and talk to them like an adult. When I was working at the VA, I called everybody sir.
Right.
Or Mr. So-and-so. We had very few females. But if we had females, it was, Ms. or Mrs., whatever. But it was always Mr. So-and-so or sir. Because, I don't care if their name's Freddie. they're in a very vulnerable situation when they come to our clinic to receive chemotherapy,
Yep.
or when they're coming and getting diagnosis of cancer. They're going to get my respect, and I'm going to show that in a variety of ways. But one is what I call them. I mean, it bothers me a lot when people call me honey or dear or sweetheart.
Jeez. Wow.
That really, really, really bugs me. But I won't go off on that now. So help people maintain a feeling of control and independence. Give people the opportunity to participate in decisions about their care or their other personal issues. You can say, do you want to wear these pants or these pants, or whatever. Give that opportunity. If it's too much for them and you see that they get really upset about the choices or whatever, well, then don't do that. But give them opportunities to make their own decision. Encourage involvement of family, healthcare providers, spirituality practitioners, anybody who can help add to that personhood. So dignity therapy as a therapy was developed by Dr. Harvey Chochinov to assist people dealing with the imminent end of their life. And dignity therapy, according to Dr. Chochinov, has the ABCDs of dignity and care. So let me tell you about those.
Yes.
The first is attitude.
Uh-huh.
Attitude is the first step to examine one's personal attitudes and assumptions regarding patients. Everyone's attitude depends on the way they've been wired or conditioned to think about or react to a certain situation. So some things that you can consider as a caregiver, as a family caregiver, as a loved one, is how would I be feeling in this person's situation? What is leading me to draw conclusions? Are they based on facts, or are they based on feelings or past history? Have you checked whether your assumptions are accurate? Or am I aware that my attitudes toward the person might be affecting him or her? Could my attitudes toward that person be based on something to do with my own experiences or my own anxieties or my own fears? And does my attitude toward my job help or hinder my ability to treat this person with care, openness, or respect? Now, the second is B for behavior. Behavior are small but powerful acts of kindness. I can remember I was working at the VA. I was on a palliative care consult team, and I was with one of our palliative care physicians, and we went to the ICU to do a consult on this elder man. And we go in, and he has a sheet over him, and he won't look at us. He won't talk to us. He's essentially mute, Charlie. And I looked at him, and I kind of touched his arm, and I said, "Are you cold?" And he kind of looked at me, and I said, "Would you like a warm blanket?" And he just sort of nodded, and I went and got a warm blanket because in the ICU they have heaters for the blankets. So I put the warm blanket around him, tucked him in, sort of that nurturing, mothering kind of tuck in.
Mm-hmm.
And you could just physically see his body relax.
Wow.
And he looked at us and he said, "So, what can I do for you?" And I said, "Well, we got this consult, and to talk with you about this." And he starts talking, to me, and he's talking to the physician, and the physician was like said some sort of joke kind of thing to him, and this guy, starts laughing, and I said to the old guy, I said, "Oh, please don't encourage him. He'll just keep going." And he's chuckling and chatting. And we did our assessment, and we left, and the physician said to me, "I had no idea a warm blanket could do that." And I said, "Well, if you're really, really cold, the rest of it doesn't matter."
Yeah.
So look at your behavior, getting someone a glass of water, helping them put their slippers on. If a person wears glasses, getting them their glasses and making sure that they're clean.
Mm-hmm.
Getting them a hearing aid. Adjusting the pillow or bed sheets. If you see a photograph or a greeting card or flowers, say something about them. Who are those from? Most recently, when I was in the hospital for that bad infection I had after surgery, the nurse who was taking care of me said, "Oh, you're a nurse." And she went and did something. She was so busy, and it was a Sunday, and she came back, and she had a sealed tube of chapstick in her pocket, and it must have, I think, probably came from one of those drug reps or something. And she said, "Here, I brought this for you. Us nurses have to take care of each other."
Oh, right. Okay.
And that was just the sweetest thing, and I still keep it on my bedside table here, and use it. It's like it was just a small thing, but it was like that was sweet. So, third is C is compassion. Compassion isn't something a person knows, it's something a person feels. It's a deep awareness of the suffering of another, coupled with the wish to relieve it. Now, some form of communication, spoken or unspoken, acknowledges that there's a person here and that there are human challenges that are accompanying their illness or accompanying their situation. And you want to be able to communicate compassion,
Right.
communicate when things are hard or difficult. And that's just part of sharing the humanness with another person. And the D part is dialogue, acknowledging that the person beyond the affliction, the emotional impact that accompanies the illness. So how a person's life circumstances could affect their response to the illness. A person with severe arthritis who's also an avid pianist. It's going to be more than just arthritis to them. It's
Right.
how they express themselves. I had a patient who was taking a cancer drug, and it was giving her severe pain in her hands. And she was a quilter, and that was her art, and that was her therapy, and that was how she earned money.
Yeah.
And it was real important to her that we fix that.
Yeah.
And we worked really hard to fix that, and we did. So looking at not only what's wrong with the person, but how does that affect them? And when you're taking care of your family members, it's like you know them, think about, geez, would they like this? When my mom was in hospice and I went to take care of her, my mom was the kind of person who got up and got dressed every day, made her bed, and didn't lay down on her bed again until she went to bed at night. I mean, she just didn't. And so every day I got her up and I got her dressed and I washed her and I transferred her to a chair, a rolling chair that she had in her kitchen, and rolled her into the living room and then transferred her into another chair because I knew she would not want to A, lay in bed all day,
Right.
or B, have anybody visit her in her bedroom. And people were coming to her house to visit her.
Yeah.
And so, it's like, what do you know about that person? Then you translate that into how you take care of them. Was that a lot of work? Yeah, because I didn't have any of the right equipment to do it. But dignity is important, and how we maintain that is important. So, part of what the intervention in terms of dignity therapy is trying to conserve their sense of dignity, giving patients a chance to record meaningful aspects of their lives and leave something behind that can benefit loved ones in the future. Now, there are training programs to be a dignity therapist, and that dignity therapist would come in and do like a 30 to 60-minute session, and the therapist asks a series of open-ended questions that encourages patients to talk about their lives or what matters most to them. The conversation's recorded, it's transcribed, meaning, they write it out based from the recording. It's edited, and then it's returned within a few days to the patient, who has the opportunity to read that transcript, make changes before there's a final version that's produced. And then the patient can share it with their family, they can share it with their friends. It's a way to let people know about them while they're alive, to tell their own story. So you can, hire a dignity therapist to come in, or you can look at our resources on the webpage, and you can use the questions and, the recording device that's in your phone or any other recording device, and do this yourself. Some questions are, for example, tell me a little bit about your life history, particularly the parts that you either remember most or think are the most important. When did you feel most alive? What are the most important roles that you played in your life? Family roles, vocational roles, community service roles. Why were they important to you, and what do you think you accomplished in those roles? Another example, what have you learned about life that you want to pass along to others? What advice or words of guidance would you want to pass along to your son or your daughter or husband or wife or others? So these are examples of questions. And, they've asked patients who've gone through this dignity therapy what they thought. And one patient said, it helped bring my memories, thoughts, and feelings into perspective instead of all jumbled emotions running through my head. The most important thing was that I've been able to leave sort of an insight of myself for my husband and children and all my family and friends. So some comments from families are, Mom was extremely closed emotionally and had huge difficulties expressing her feelings. This gave her an opportunity to do so without feeling vulnerable. Another example is he felt that our grandsons, including our latest, whom unfortunately he never lived to see, would get some idea of his life and what he had achieved. So that's kind of an overview of dignity therapy. And Charlie's going to introduce our guest and our interview with Dr. Harvey Chochinov.
The Manitoba Palliative Care Research Unit is directed by Dr. Harvey Max Chochinov, who holds the only Tier 1 Canada Research Chair in Palliative Care of the Canadian Institutes of Health Research, CIHR. For the last 17 years, Dr. Chochinov's program of research has earned him recognition as one of the world's leading palliative care scholars and researchers. He is also a distinguished professor of psychiatry at the University of Manitoba. Dr. Chochinov and his internationally recognized team has successfully broached difficult topics spanning end-of-life distress, depression, desire for death, and will to live, hopelessness and its connection with suicide, personality and coping at the end of life, and finally, the issue of how to help patients die with dignity. We hope you will learn something new from our interview with Dr. Chochinov.
Hi, it's my pleasure today to be talking with Dr. Harvey Chochinov, who is Charlie introduced him. I don't have to tell you who he is. But he's kind of the father, I guess we are the father of dignity therapy. And I'm interested to know what inspired you to embark on this work in dignity therapy.
Well, it's an interesting story. I'll try and give you the abbreviated version. I'm a psychiatrist who became interested in the area of psychiatry and cancer many years ago. Did some studying at Memorial Sloan Kettering Cancer Center, came back to Winnipeg, started a psycho-oncology service here at Cancer Care Manitoba. And for the first number of years, in terms of my own research, we were looking at, very psychiatric-like entities. For example, depression, anxiety, desire for death, in the context of life-threatening or life-limiting illness. During that time, we happened upon literature that was coming out of the Benelux countries that was looking at why dying patients were asking their physicians to provide them with euthanasia or assisted suicide. one of the papers by Paul Vandermaas, published, I believe it was in The Lancet, reported that the most highly cited reason, according to Dutch physicians, as to why their patients sought out a hastened death was a lost sense of dignity. Well, we looked at the literature, and dignity was cited all over the place, but there was nothing empirical. So dignity is something that is highly politicized, and people use it to support whatever argument, especially contentious argument they might have with respect to end-of-life care. But no one had studied it, so we decided that we were going to study dignity, and that was the paper that really put us on the path of dignity research, which eventually led, for various reasons that we can go into later if you like, arrived us at dignity therapy.
Mm-hmm. And so when you think about dignity, if you were going to define it in sort of a non-political way, how would you define dignity?
Well, I think, after years of being kind of immersed in it, the definition of dignity still is probably one that is most helpful. The idea of being deserved of honor, respect, or esteem. So does someone continue to have value? It reminds me of Dame Cicely Saunders' kind of famous aphorism when she talked about, you matter because you are you, and you matter now, and you matter till the end of your life. Well, dignity is about mattering. It is about maintaining value or worth to the very end of your life. Now, if we were going to be a little bit more empirical and start to look at the research, our group developed the first empirical model of dignity at end of life. And so this model of dignity in the terminally ill, basically it lays out the various different things that can cause distress that might be affiliated with sense of dignity. So we showed that there are things that are mediated by way of the illness itself, or what we called illness-related concerns. There was another category that we called dignity-conserving repertoire, which really had to do with the psychological issues and the spiritual issues that are important in supporting or undermining sense of dignity. And then finally, there are the external issues, or what we called the social dignity inventory. And these are things that can happen from outside of that individual that can have a sense, or that can have an impact on their internal sense of dignity. So the model says that what your illness does to you, the psychological environment that you are bringing to the experience, and the environment, the social environment, all could have an influence on sense of dignity.
That makes sense. That makes sense. And I've heard patients, I've worked as a hospice nurse myself, I've heard patients who've said, they have this line in the sand in terms of their disease and being willing to continue either with treatment or with hospice care, continuing to live, as long as that line in the sand isn't crossed.
Right.
I remember my sister was sick, and I said, do you have a place where you would, feel that your life wouldn't be of value to you anymore? And she said, if I can't wipe myself anymore. And so there's that. Do you find that too, that people have a place where it's like, I don't want to go past this point?
Yeah, it's a good question, Marianne, because many people, have that idea of the line in the sand. So when you ask people, for example, about their support for euthanasia and assisted suicide, in public opinion polls, the vast majority, certainly in Canada, the majority of people would support the idea of euthanasia or assisted suicide if they were facing a life-threatening or life-limiting condition. What's interesting, though, is that when you look at the number of people who would support it from the vantage point of being healthy, and then ask people who are actually dying, well, I mean, the fact is that although 60-70% of Canadians would support euthanasia and assisted suicide, right now, and in Canada, euthanasia has been legalized, but it accounts for somewhere like around 2% of all deaths. If you look to Oregon, assisted suicide accounts for less than 0.5%. So I guess what I'm saying is that I think we all have this perception, this idea that there is a line in the sand. But the fact is that the line is shifting. And when we get sicker, the line begins to shift and our own perceptions begin to shift. I just was reading through some interviews lately of some patients and their experience of end of life and talking about, for instance, accommodating to the fact that they have to be dependent on others for intimate care. And, one gentleman was saying, this is my life now. I mean, this is what I need to be able to go on. And so the point is that we have this idea that there's a line in the sand, but the line really varies depending on how sick we are. I think for most people, a profound line in the sand has to do with no longer feeling a sense of worth. And again, it gets back to the issue of dignity, to be deserved of honor, respect, or esteem. So if you feel you no longer have worth, in fact, we had one of our studies that said, no longer feeling like I'm the person I once was. Over 70% of patients in our study said that's something that they would affiliate with their sense of dignity. But the things that were most highly affiliated with lost sense of dignity were feeling a burden to others, which really is, I think, the equivalent of kind of existential extremis, this idea that I no longer serve any function. I no longer have any value. I take up space and I take more than I can give. And the other thing that was most highly affiliated with it, along with burden to others, was no longer feeling deserved of being respected. So I think for many people near the end of life, that seems to be the line in the sand. And what I've called that line in the sand really is something that I think we can call personhood. When you feel personhood is being undermined or fragmented or fractured, it really harkens back to kind of Cassell's notion around suffering and the idea that when we feel who we are as a person is under assault, our suffering is proportionate.
I read a study quite a long time ago about homeless people. I don't know if you're familiar with this, where they talked with homeless people about what their various issues or concerns were, and what kind of rose to the top for them was not being treated as a person. That if they were seen on the street, nobody would make eye contact with them. Nobody would say hello to them. They would just pretend that they weren't there. And ever since I read that study back in graduate school, I have made it a point to always look people in the eye and say hello. And the response I get is one of shock. It's like almost like, what, me? You're talking to me? They're not expecting to be seen. And I think that also happens with people who are at the end of life. They're not expecting to be seen. Even, when you and I were younger in our careers, the person who was dying was put at the end of the hallway and the door was closed and they were left alone.
And non-teaching.
Like some sort of misguided notion that gave them their dignity so that they could do that alone.
No, you're absolutely right. This idea of not being seen is an important one. A number of years ago, I published a paper in the Journal of Clinical Oncology that I called "Dignity in the Eye of the Beholder," and I kind of make the case there that we in healthcare are the beholders. I mean, we are the witnesses to what our patients are going through, and at least metaphorically, what our patients are looking for is a reflection in the eye of the beholder that is affirming of their sense of dignity. So if we avert their gaze, there is no reflection. And if they look in our eye and all they see is a problem checklist or a differential diagnosis, then they feel they have become their illness. But if we can provide them a reflection of the entirety of who they are as a person, then I think we can uphold or maintain their sense of dignity.
Or even nowadays with people bringing in laptops and that kind of thing into the room, and they're checking off the boxes in the laptop, and I sit there and I think, you haven't looked at me once. You're looking at that darn computer.
Yeah.
And it really annoys me. Have you had that experience?
Oh, I've absolutely heard patients talk about that. The fact that more attention is being paid to the computer or is being paid to the chart, as opposed to attention being paid to them. So, there are some pretty fundamental human issues that we need to consider if we're going to be providing what I've called dignity-conserving care. And what we need to be mindful of, again, hearkening back to another study, we looked at what things affect a dying patient's sense of dignity. And one of the things that came out very strongly in one particular study was this notion of how people perceive themselves to be seen. Well, that really implicates the healthcare provider. I mean, we are the witnesses. So if we cannot provide an affirming reflection, if we can't provide feedback to the patient that they continue to be seen, that they continue to have value, then that person is apt to feel that they don't matter. They've disappeared. Their experience is inconsequential.
What kind of things can families do and healthcare professionals do to ensure that people are seen?
Oh, that's again, it's a wonderful question, and it depends on a variety of things. Again, it harkens back to how we understand the notion of dignity. And the fact is that if we look at the model of dignity in the terminally ill that I referred to earlier, what we find out is that there are a variety of things, and they're really person-dependent. So there are a variety of things that can influence a patient's sense of dignity. So, for example, if somebody is in pain, if they have poorly controlled symptoms, well, their world quickly becomes very small and revolves around the pain experience. So a profound dignity-conserving intervention is good pain management. We can make sure that we are highly attentive to patients' symptoms. The other thing we can do, going more into the kind of psychosocial and spiritual realm, again, if a person is no longer feeling like the person they once were, involving people in discussions, involving them in healthcare decisions, just involving them in the everyday things that are happening in life, and not somehow forgetting the fact that they continue, besides the illness experience, the essence of who that person is continues to exist. Now, in dignity therapy, and I know that's something that you wanted to speak to as well, one of the things that we do there is we deal with this notion of generativity. So we found in our model that for some patients, the thing that undermines their sense of dignity is feeling as if their life will not have made a difference, that there won't be a ripple effect, if you will, to generations to follow as a result of the fact that that person lived. And so with dignity therapy, bearing in mind generativity, what we do is we give people an opportunity to have an influence, and it's to have an influence in a way that will even be transcendent of death, to create a legacy document that will be available to their family members who will soon be mourning their loss.
And so can family members do this with, the picture books or the picture boxes? I can remember when my mother died, we'd look at pictures and say, so who the heck is this? Because it wasn't written on the back. The date wasn't on the back, and all we could do was guests. So are activities like that something that would help promote, other than this generativity document, would that help promote that personhood?
Oh, I think it can. Dignity therapy is something that is therapist-led and it's highly formatted. Mm-hmm. I've written a book that really contains a protocol, but not everybody necessarily wants, needs, or has access to that. But fundamentally, I guess, it always occurred to me, I would meet with patients in my office and I say, I really can't, I just can't do anything anymore. I'm useless. I'm a shadow of the person I once was. And yet here, I've spent the last hour in my office talking with them and, deeply engaged in conversation about what matters to them and what's important to them and what makes their life meaningful and what made their life meaningful. And I think to myself, well, you say that you can't do anything, but you sure have the ability to be able to express yourself and to share who you are as a person. I was just reading a transcript, and a doc was talking to a gentleman who had an end-stage colorectal cancer, and he said to the patient, you have an opportunity here. This was a man who had recently been told that he had only, a few months to live. And his doctor said, you have an opportunity here, and the opportunity is to share things, with the people that you love so deeply, and this is a gentleman who had a spouse, who had some children, he had grandchildren. And what this man ended up doing is he made meeting times with each of these people individually to share with them, some of his outlooks and some of his perspectives on their lives and give them words of guidance that they perhaps could use in shaping their lives as they move forward in a life that would soon be without him. So, dignity therapy is a highly formatted way of doing this, and I think in an interesting and important protocol for some patients. But for family members, engaging people in discussions, this is a final opportunity to find out what matters to this person. What are the things that they would want remembered? What are the things that they would want known? What are the things that were important to them? What important roles did they serve in their community? What do they feel proud of? What do they want to say, or what do they want to say again? What are hopes, wishes, or dreams for loved ones? What have they learned along the way that they would like to pass along? What advice or guidance do they have for their children or grandchildren? Are there important instructions that they would like to provide or offer to family members in anticipation of a time when they won't be here? These are all things that we can be asking of the people that we love. And not only does it give us something to take away from that, but it also gives the person who is conveying those things something, and that is it reinforces the fact that they continue to be an important person, that the things that they feel, the things that they felt, the things that they hold to be important and dear continue to be. So it is an affirmation of personhood.
And I think that's really valuable, and it makes me think of when I talk to my girls about something in their lives, and I'll say, you didn't ask this, but I would like permission to give my opinion. And they'll say,
right,
permission granted, and I'll give my opinion. And what they'll say is, okay, I hear you. And that makes me feel good. It's like a validate. They might go and do just, or probably will go and do exactly whatever the heck they darn well please. But to know that I had something I felt was important for them to know, they could verbalize, I hear you. I might ignore you, but I hear you. There's that respect that you're talking about. You're saying, that not receiving that respect. There's that mutual respect between people. And I think that that's an important aspect, because even with family members, I'll see family members will, especially if it's an older person who's in hospice, is they begin to treat them like their children. and not treat them like they are the adult patriarch or matriarch of that family. And kind of the illness strips them of that, or the family allows the illness to strip them of that. And do you see that, and do you kind of try to reframe that for people in terms of this is still your parent?
Absolutely. I mean, the illness can threaten to strip that from people, but we too can feed into that. So if we begin to make them feel that somehow their words are no longer valued, that what they have to say isn't as important as it once was, that they don't continue to play a role in our emotional lives, then people begin to feel that, prematurely that they have died before death has actually claimed them. So trying to remind people, there are I'm just thinking of a wonderful anecdote. There was a geriatrician by the name of Colin Powell, not the Secretary of State, but the geriatrician who worked in Eastern Canada. He talked about a case of an elderly man who was near end of life and had some mild cognitive impairment and was beginning to have some kind of behavioral discontrol. And when Colin went in to review the chart, he found out that this person had been, this was in like the equivalent of your VA hospitals, that this had been a highly decorated Canadian soldier. And so besides anything else that he said that we needed to do, is we needed to start calling him by his formal titles, lieutenant colonel. And that was an acknowledgement. And whether it was the definitive thing is hard to say, but this man started to settle down. He no longer, personhood was no longer under assault the way it had previously been. There was something in geriatrics called elder speak, and elder speak is a way of kind of speaking to the elderly in this infantilizing way. It's time for our bath, dearie. This is what you want, isn't it? I mean, sort of. Pointing people in the direction of answers that you want them to have and referring them into ways that are infantilizing and are generic. So the fact is that if you're dearie or sweetie and everybody else is referred to in the same way, then it really gives the message that, what your name is really doesn't matter to me. It's unimportant, it's generic. And if you're deserving of that affection, and everyone is deserving that affection, well, then perhaps really the reality is that no one is deserving of that. So elder speak is an important thing that we be aware of and not fall into, because it belittles people who are aging. And the last thing we want to do is to be contributing to the suffering of somebody by disavowing who they are.
I wonder if as the baby boomer generation kind of moves into that place, if we're going to be very patient with that kind of behavior, because already, I'm 64, and people will be honey and sweetie me, and it just is all of my self-control not to say something polite.
And knowing you as I know you, I know what you might say.
Exactly, right? But, just give me a little bit of, cognitive changes, and I might lose the filter of, not saying what I'm thinking. And it probably wouldn't be very pretty. Where, older generations, had more, I think, that put the doctor or the nurse up on the pedestal, and whatever they said was perfectly fine, and were much more compliant with what they were told to do than I think the boomer generation has ever been. So I guess we'll see how that plays out.
Yeah, and in those studies of elder speak, they've shown that the more people are exposed to elder speak, the more likely they are to be combative and to demonstrate resistiveness to care.
Well, and, you can see that if they're not going to be able to say, to respond to that in whatever way they want to, they might respond in the way that they can, which would be to resist care, kick somebody or something like that.
Yeah.
So do you see changes in kindness and respect in when I was thinking about this, I was thinking about American culture, like in the last 5 years. I've seen some real changes in how people talk to each other. And I don't know if you see that in Canada, if you've been as affected by that. But there's less respect, less restraint in terms of, I guess I would call it rudeness, in probably the last 5 years. And do you see that as either having or potentially having an effect on treating people with dignity?
Well, of course. Because again, the essence of dignity is about deserving of honor, respect, or esteem. And when you think about again the model of dignity in the terminally ill and the social dignity inventory, the fact is that dignity and respect specifically is something that can be withheld or conferred. And so we in healthcare are always in a position to be able to have an influence on our patient's sense of dignity, whether we like it or not, whether we buy into that or not, because there is no neutral position. If we walk into the room of a patient and we show nothing, not that we show animus, but we show nothing, then patients experience that as a rejection, that, again, I guess I really don't matter. And the irony is that we spend the entirety of our professional careers learning how to look after patients, and the one thing that people don't want is to be seen just like another patient, because patient is generic. Patient is something that can be put into objective categories. Persons are individual. They're unique. So, I do see that as something that can affect the way people will be treated in the context of healthcare.
Do you have any last thoughts or anything that you want to have our listeners know about dignity in the end of life? Like parting words?
I guess, maybe if anything, it would be to raise their expectations. People have this sense or notion that dying is going to be horrible, that end of life is going to be filled with suffering. And if that is their expectation, then they don't necessarily expect that they're going to be provided with the kind of care that ought to be forthcoming. So palliative care is one of the areas of medicine that I think has really tried to get this right. And again, it harkens back to Dame Saunders, the founder of the modern hospice movement, who talked about the fact that, we need to be attentive to the physical realities that patients bring to us, the psychological realities, as well as the spiritual context. And those things need to all be acknowledged. So, and I think patients and families should expect nothing less and deserve nothing less. I guess the last thing on dignity is that I certainly, in my work, although we have developed an intervention that is protocolized and has a manual and has lots of papers in the literature with phase 1 and randomized controlled trials, the fact is that dignity has been around as long as people have been around, and so let's not think of it as something that is highly medicalized. Let's think of it as a human quality that we can try and understand, that we can try and provide to the people that we love. If we can continue to provide the people we love with an appreciation of who they are or who they've been till the very end of life, and never forget that, then I think that we can be providing them with the kind of care that will be supportive of their dignity to the end of life.
Those are incredible words. And I want to thank you, Dr. Harvey Chochinov, for being my guest today and talking about this. And I really appreciate the work that you're doing. And thank you.
You're very welcome. I'm so glad to have reconnected with you as well.
With that in mind, please stay tuned for future episodes of Everyone Dies, and thank you for listening. This is Charlie Navarrete, reminding you that our dead are never really dead to us until we have forgotten them.
And I'm Marianne Matzo, and we look forward to talking to you soon. Remember, every day is a gift.
This podcast does not provide medical advice. All discussion on this podcast, such as treatments, dosages, outcomes, charts, patient profiles, advice, messages, and any other discussion are for informational purposes only and are not a substitute for professional medical advice or treatment. Always seek the advice of your primary care practitioner or other qualified health providers with any questions that you may have regarding your health. Never disregard professional medical advice or delay in seeking it because of something you have heard from this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Everyone Dies does not recommend or endorse any specific tests, practitioners, products, procedures, opinions, or other information that may be mentioned in this podcast. Reliance on any information provided in this podcast by persons appearing on this podcast at the invitation of Everyone Dies or by other members is solely at your own risk.